Okay. Good morning, everybody, and thanks for joining us for this month's installment of the Survivorship Lecture Series. We have two wonderful speakers today that work closely together. Dr. Nicole Gastala, we were just talking about her role, but she is boarded in both family medicine and preventive and addiction medicine, and she has a certificate in primary care psychiatry addiction. She joined UIC in 2018 and has gone through some permutations, but now supervises family medicine residents and med students at Miles Square Health Center and the curriculum at UIH, and is the Senior Director of Research, Behavioral Health, and Addiction Family Medicine and Addiction Medicine, and co-directs the methadone program at Miles Square Health Center, and splits her time between that with the medical director for the Substance Use Prevention and Recovery Division of the Illinois Department of Human Services. So not sure how she balances all that work and kids at home. So her partner in crime today is Brianna McQuade. She is a doctor of pharmacy. She was a staff pharmacist at UIH, and now she's more specifically a clinical pharmacist at Miles Square Health Center in particular, where she kind of oversees substance use disorder and mental health pharmacy. She also teaches at the UIC Pharmacy School and works very closely with Dr. Gastala. So ladies, you are able to share your screen, I believe. So go ahead, take it away.
Great. Nikki, do you want me to share my screen?
Yeah, go ahead, and then we'll just switch halfway through. So we split up this.
Okay.
We're really excited to be here today to talk. We're going to do some education on medication management, but as well as sort of discussing opioid tapering and the risk of opioid use disorder. And we're going to talk about actually in both acute, surgical, and chronic, because you're going to sort of get all of these scenarios, right, with patients in survivorship, depending on sort of where they're at. So I'm going to hand it off to Dr. McQuade to start us, because she's really our medication expert and will be able to give us some great insight.
Great. Thank you so much. Hi, everyone. Thanks, Deb, for that introduction. My name is Brianna McQuade, and I'm excited to be talking to you today about something that comes up a lot in our clinic, people with substance use disorder, specifically opioid use disorder, and their co-occurring pain syndromes. And so let me kind of take us through our learning objectives, and I'll break it down a little bit further. So first, we're going to give an overview of what opioid use disorder is. Believe it or not, you can use heroin and not have an opioid use disorder. So I think that's an important distinction, or use somebody else's prescription opioids and not have an OUD. So we'll kind of talk about the spectrum there. And then we're really going to spend some time focusing on buprenorphine, because I think that perhaps some of the biggest fear of this patient population is just managing their OUD. And then you can kind of focus on the pain on top of that, right? So having a good understanding of the OUD treatment kind of opens the door for everything else. And then by the end, I hope you'll be able to build some processes and workflows for caring with patients with chronic or acute pain, as well as co-occurring OUD. And obviously with a specific lens on cancer survivors. We have no financial disclosures, fortunately. Okay, so OUD treatment. This is kind of the overview of what's indicated. So obviously there's the behavioral health support, so individual counseling, kind of your formal treatment programs, Narcotics Anonymous, et cetera, which is something that's absolutely important, but as physicians and providers, we can really focus on the medications for opioid use disorder, because this is something we should be offering to everyone. The FDA approved medications for OUD, methadone, buprenorphine, plus or minus co-formulated with naloxone, and then an extended release injection, naltrexone. It's really important to note that detoxification or supervised withdrawal is not an appropriate treatment for patients with OUD. It can actually just astronomically increase the risk of overdose, because you're not kind of treating the underlying neurochemistry imbalance, psychosocial issues, right? So they basically lose their opioid tolerance, they go back to their same behaviors and overdose really easily. Unfortunately, despite what the opioid epidemic and the elevated overdoses. We've been consistently having 100,000 opioid-related overdoses since the pandemic started. Previously, it was hovering in like the 70,000 realm. Only 1/3 of substance use treatment providers offer methadone or buprenorphine. And I'll kind of talk about the evidence behind these and why they should be offered to everyone who's interested in treatment. So SAMHSA recommends that medications for OUD should be offered as a clinical standard of care. So it's really important that kind of our frontline providers, so primary care, ED, internists, things like that, should be aware of the resources for MOUD and should be offering it to patients and have this as kind of in your back pocket, like you would an endocrinologist for somebody with uncontrolled diabetes or a cardiologist for somebody with complicated heart disease. Because compared to behavioral therapy alone, MOUD decreases illicit opioid use, retains patients in treatment, and reduces mortality. So it does everything we want it to do. And again, what we've been doing previously, encouraging people just stop or ignoring it, or I don't know, go to Narcotics Anonymous only, abstinence is the only treatment, has not been working. Some pushback from the general community, the medical community is, why would you treat an opioid addiction with an opioid? And here's why. So kind of on the left here, you see in the acute phase of using opioids, people go through these kind of peaks and valleys. So they feel normal, then they use for the euphoria, and then they kind of peak and valley and they continue to use. Once you start getting into this chronic use, the tolerance and the physical dependence of opioids, people are using mostly to avoid withdrawal, right? So they're using to feel normal. And so when we replace that kind of opioid deficit with agonist therapy, that's when people can maintain that normal balance. They have sustained levels of opioids in their system, and they're able to participate in their lives and be functional, be a functional member of society. So again, buprenorphine is kind of the biggest option we have, because any provider with a DEA can prescribe buprenorphine for opioid use disorder. Whereas methadone has to go through specialized opioid treatment programs, has to be lots of federal guidelines that people have to follow. It can't be necessarily, offered in clinics. Buprenorphine can. It's a prescription that goes through the pharmacy, just like any other medication. And it's also a really cool drug. I have no stock in any buprenorphine product. It is the coolest drug, okay? So step number one, it has a really high affinity for the mu opioid receptor. So what that means is that when it's on that mu receptor, it is on that receptor, and it's gonna take a lot to knock it off. So if somebody has buprenorphine on board and they use a full agonist on top of that, it protects them against overdose. On the flip side, it will displace any full agonist on the mu receptor. So you have to be careful in initiating it because it can precipitate a withdrawal. It has a slow dissociation from the mu opioid receptor. Something here actually that I don't think is explicit. It's a partial mu agonist, whereas heroin, fentanyl, kind of your morphine, oxycodones, those are full agonists. So that's why when you have this partial agonist coming on board, it'll precipitate a withdrawal. We'll talk more about that. And then it binds to those receptors really well. It's with a slow dissociation, so it can be dosed once a day. Again, getting those level serum levels that we kind of want for people to be able to function. And then it has the partial agonism comes into effect for safety, which is fantastic. So it's really, really, really difficult to overdose on buprenorphine, particularly in the absence of other substances. And it's a really poor drug for intoxication purposes. Most formulations now come co-formulated with naloxone. Naloxone doesn't have any therapeutic function. So when somebody takes their buprenorphine naloxone sublingually, naloxone is not absorbed. If it's swallowed, it's not absorbed. But it does deter people from injecting or insufflating, because then the naloxone theoretically is active and it'll have that full blockade of the mu receptors. And so it's an abuse deterrent. This is a great slide just highlighting that buprenorphine and methadone, again, do everything we kind of want to see in this patient population. I mentioned extended release naltrexone. Unfortunately, there's no evidence that it reduces overdose or mortality. The only thing we've really seen with that is, in particular compared to buprenorphine, it has similar retention and treatment and reduced illicit opioid use. But buprenorphine and methadone, again, kind of do all these things that we want to see. And so that's why a lot of, SAMHSA, ASAM, all these kind of addiction accrediting bodies really push for offering MOUD. And again, traditionally, kind of in the past, we've focused on, okay, if their urines are negative for substances, that's a great goal. Now we're kind of looking more at broader outcomes, because again, what we were doing was not working. So retention and treatment is a really important outcome for this patient population. I think we can all kind of relate to like smoking cessation, right? Somebody comes in on day one, they might not be ready to smoke or quit smoking, excuse me. But they see you, they build that relationship with you, you can plant the seeds, and eventually they might be, in that contemplative stage, action stage. Same with opioid use disorder, and coupling that with a lot of these patients are not engaged in care at all. And so you can kind of chip away at other conditions that they have as well. So that's a really important outcome. And then buprenorphine and methadone really kind of take the cake with engagement and retention and care, as you can see here. So I don't want to, I kind of beat this point to death, but you can see that there's buku evidence that MOUD really improves mortality and reduces overdose deaths. Okay, so now that I've hopefully convinced you that all patients who are interested in treatment should be offered MOUD, let's talk a little bit about caring for the patient who is on MOUD, right? So we use opioids a lot for pain management. What do we do when somebody A comes in who has an addiction and misuses opioids, and B is already on a methadone or a buprenorphine? Short answer is you keep them on those medications. Okay, so in the acute pain setting for surgery, long story short, you keep them on buprenorphine. And the reason for that is there is a high risk of relapse if they go off of it, and then kind of titrating them back up. You're kind of worried about you're feeling that opioid deficit, right? And when you take away that opioid deficit, you're actually going to need more opioid pain medications post-surgery. And so if you kind of keep them at that level and then go from there, then that's just better around for the patient. It's better for the healthcare system. So hence the things we do for no reason, discontinuing buprenorphine when treating acute pain. This is a really great article. It's like 2 pages. I highly recommend you download it and read it. But essentially it says the things I just said, right? There's no indication to remove them off their buprenorphine because of risk of relapse, of needing higher opioid requirements, and then just the issues of getting them back on that therapeutic buprenorphine post-acute pain syndrome. And this article really highlights that as well. So you can see that in patients who take buprenorphine and methadone, when you actually took them off of their MOUD, they actually required higher amounts of opioids for pain management.
So I'd say that this study is really important when you're arguing with anesthesia or,
yes.
or surgical teams or anything like that. The biggest thing is do not take them off their medication because you create an opioid deficit, whether it's buprenorphine or methadone. Don't take it off, just keep it and add on like agonists if you need to.
Absolutely. And yeah, absolutely. And so the other thing that the things we do for no reason in the buprenorphine article discusses is that, so again, buprenorphine being a partial agonist, some people are like, okay, well, isn't that going to block the effects of pain relief with opioid agonists? And actually that has not been shown to be true, because there are different receptors that agonists and partial agonists work on that can facilitate pain relief. So it's not just the mu receptor. They might need slightly higher doses of opioids than you would start in, let's say, somebody who's not on buprenorphine. But they do still get additional pain relief when that opioid agonist is added on top.
And the other thing too that happens is, so it's a dynamic process, right? So buprenorphine, there's, millions of receptors, they're coming on and off all the time. So you do get some agonists that bind as well.
Yep.
So that's another sort of reason why that myth has sort of been debunked.
Yep. Perfect. Thank you. So again, we should be maximizing our multimodal analgesia, right? So everything you would traditionally think of, APAP, Tylenol, NSAIDs, gabapentin, muscle relaxants, topicals if indicated. Another trick is to split the dose of buprenorphine. Buprenorphine's analgesic effects are 4 to 6 hours. So if somebody's on 24 milligrams a day of buprenorphine, split that up to TID or QID dosing, and they'll have better pain relief. So that's one trick. So buprenorphine, do not forget, is also a very effective pain medication. And then, yes, if you do need to, you can absolutely add full agonists. The evidence for even like discharging patients with OUD with a short course of opioid agonists if needed, there's no evidence, or the evidence does not support that they relapse or overdose or things like that. It's ethical and compassionate care to give somebody pain medication for their acute pain syndrome. So the approach so as we're kind of transitioning now into chronic pain syndrome, I think this is a good approach for both acute and chronic pain, but just set expectations, right? So pain is a normal part of illness and healing. And sometimes it's unrealistic that people will be pain-free, not sometimes, often all the time. And the focus is really that, you can live a life with pain and still achieve the things you want to achieve. So let's get you there, right? I'm not going to bring your pain from a 9 to a 0. So setting expectations is really important. And especially in the chronic pain realm, a lot of patients with addiction have chronic pain. A lot started using opioids to control their pain, particularly in the mild square patient population. It's easier to get heroin than it is to come to the doctor. So that's a really important piece, and something that a lot of patients will struggle with. It's also like chronic pain is really complicated, right? Biopsychosocial roots. There's a huge mind-body connection in that, there's pain and then there's suffering, right? So people will catastrophize their pain. They'll really, kind of go down this really unhelpful mental pathway that absolutely exacerbates what they have going on. And so really educating patients around that. And I think the other thing I want to mention is when you kind of enter this chronic pain realm, even just as simple as educating the patient, like, there's nothing wrong, right? So you break your ankle, it's painful. That's your body saying, don't walk on me until I feel better. Chronic pain is more of, we've kind of ruled everything out. We're taking care of everything. So you can rest assured that there is nothing wrong, right? And so sometimes just as simple as reframing it that way is really helpful for patients. So again, pain catastrophization is a huge piece of it. This is why behavioral health interventions for chronic pain is so huge, and actually medications are not great. But this is kind of a questionnaire to kind of have the patient, think through like, okay, what is the role that my mind has in this? So with that in mind, an overview of chronic pain treatment. We have some non-pharm on this page, which again, I think is really, really important and it's kind of a tough sell for patients. They'll be like, what are you saying? Like, my pain's in my mind. No, that's not what I'm saying. Your pain's very real, but there is, a mind component. So I do want to highlight a couple of things here. So one is sleep. A lot of patients who don't get good sleep, that contributes to their chronic pain, and their chronic pain contributes to poor sleep. So it's a vicious cycle. So if you can even help them sleep better, that is a huge way of dealing with or handling their chronic pain. Mindfulness, my personal favorite. I teach a mindfulness elective at the College of Pharmacy. And again, mindfulness really just helps people work with like the catastrophizing thoughts and, okay, like this is happening, but what's my mind telling me versus what is the actual truth? Connectedness, so 12-step and spirituality is also really helpful for a lot of people. I think spirituality in particular is really helpful for our patient population. Exercise, I do want to highlight, it doesn't even have to be like, okay, get up and run around the block, right? It's movement in general. Like, let's set baby rules, right? So you sit on your couch all day. Can you get up and go get the mail one day? Or at work, can you take the stairs once a day? Things like that. Just simple movement that, or, if you have low back pain, can you lift weights while watching TV? So just things that like seem surmountable. And then Dr. Gastala, I don't know if you want to talk about TENS at all. The transcutaneous electric nerve stimulation also has some pretty good data for chronic pain management as well.
Yeah, and that, I mean, if you think about it, it helps disrupt that, like the nerve receptors, right? And so it helps sort of break some of that pain cycle that they may be having. And I'm sure if, like, you've all noticed, like if you are having pain, then you tense up, right, more, and then it sort of recycles that sort of pathway. And so it sort of breaks that up so it can become more manageable, or to prevent sort of that pathway from re-emphasizing on itself. The other thing, like getting back to what Dr. McQuade said about exercise, sometimes it's even as simple as outdoor time, right? Like, so getting them out of their home or out of that environment, especially if their environment's very traumatizing, which many of our patients are, just saying, going for a walk, walking to the store, so getting out of that house or apartment or shelter, it can be sort of like that critical them time. And it's natural for people not to want to feel pain, right? Like, if we put ourselves in their position, it's very natural for them to not want to. So it's about using sort of that multimodal approach to help them to make it manageable.
Absolutely. And I think a lot of folks, like, no one's just ever sat down and talked them through this sort of thing, right? Okay, so my bread and butter here, medication. So let's talk about some non-opioid options that are absolutely perfectly appropriate for people with OUD, and probably more of your first line for even people without OUD. I will put a shameless plug here, and I think we might talk about it a little bit later, but essentially opioids have minimal long-term efficacy data. What we have seen is long-term harms. And so in most circumstances, chronic opioid treatment for chronic pain syndromes is not warranted. That is not to say that somebody who is on chronic opioid should be immediately taken off of them. That's not what I'm saying. I'm talking about opioid naive patients. So we should really be exhausting our non-opioid modalities, which most evidence shows are just as effective as opioid therapies, particularly in the short term. And sometimes it's just about the right combination, right? We've all had the patient come in and say, Tylenol doesn't do anything for me. Well, have you tried Tylenol scheduled with gabapentin? Or, the combination might make a difference. So our antidepressants that we really like, so duloxetine is FDA approved for both neuropathic and musculoskeletal pain. Also a great mood moderator. So somebody with, kind of down mood or concurrent anxiety, this would be a great option. We use it a lot. Tricyclic antidepressants, so like amitriptyline, nortriptyline. We also use a lot for pain and also to help sleep. So that could be a good option for people with sleeping issues. Gabapentinoids, we use gabapentin for a lot of things. We use it for alcohol use disorder, we use it for pain, we use it for anxiety. There is kind of this caution here that, again, we're using it a lot for off-label for pain. We use it for musculoskeletal and neuropathic, but it should be noted that there's actually limited evidence for this. I will say anecdotally, I think it really helps with kind of the catastrophizing that goes along with it, again, so like the anxiolytic effects. And then it sometimes really helps people sleep as well. So if you can target that sleep, that's really important. Alpha agonists can help with that kind of central pain modulation. We'll use clonidine a fair bit, not so much for pain modulation, but to help again, kind of with that, the opioid withdrawal, that sympathetic output that kind of comes as somebody's trying to, wean off of their opioids. Tizanidine also is a really good agent. It's a muscle relaxant. And again, it can be really helpful for folks for sleep. It also has geriatric dosing, which is really helpful because some of the other muscle relaxants are on the Beers criteria. Okay, so a little bit more about muscle relaxants. Diazepam or cyclobenzaprine, potentially for some like acute issues. However, in people with opioid use disorder, we try to avoid benzodiazepines if we can. Baclofen can be really helpful for true spasticity. And as I mentioned, tizanidine kind of has a leg up on all of these guys because of the reasons I just mentioned. NSAIDs, APAP is not an NSAID, so sorry about that. But acetaminophen, we should be avoiding if liver disease, but they can still have lower doses. I would say, unless their liver is like just like a brick, right? It's absolutely dead. And then NSAIDs, I love NSAIDs. I just wish we could use them more. Obviously, limitations in kidney disease, history of GI bleeds, really bad cardiovascular disease, really acute cardiovascular disease. But again, the Tylenol NSAID combination has been shown to be just as effective as opioids. So really, if you can use it, particularly in these acute pain syndromes, do it. And then there are topical NSAIDs that are possible in with people maybe with really bad like knee osteoarthritis. I mentioned the side effects of NSAIDs. This kind of breaks it down here. I think the takeaway here is that so celecoxib is a COX-2 specific inhibitor, so it had kind of gotten hailed as like a safer NSAID, and I do think it can be used safely, even though there was a lot of concern for increased cardiovascular events, but it tends to be better on the GI lining because the COX-1 inhibition is kind of what breaks down that prostaglandin that maintains the mucosal integrity. The other thing I want to point out is naproxen. Naproxen tends to be the most CAD neutral. So in people where you might be worried about cardiovascular events, then naproxen is appropriate there. Marijuana, this is a huge topic. I get asked this a lot, and I wish I had better answers for you. Long story short, there is some evidence that it can help pain. I think, again, that it helps more with the sleep, maybe the anxiety. However, once you stop using it, cannabis like that, it like exacerbates your anxiety. So I think it's kind of a double-edged sword. The evidence just is really tough because it's not well studied. What is studied is different formulations, right? The THC CBD ratio is different. It's topical, it's inhaled, it's oral. We just don't have a standardized formulation. And so it's really hard as a pharmacist for me to weigh the benefits versus the risks. In the setting of somebody with OUD, I have two thoughts of the subject. One, if it reduces their opioid use, great. At the same time, they've already proved they have addiction, and THC addiction is a thing. So just some things to be cognizant of. And again, all of these studies exclude people with addiction. So that's that. And that's kind of what this slide says here. It might be outweighed by potential harms. I really don't have a good answer for you. Usually, again, if people say they do it, I'm not wasting my breath telling them not to, unless I'm concerned for, unless they're under 21 or things like that. Harm reduction with this, encourage ingestion versus inhaled. Okay, cool. So this is kind of just recapping the approach. This article is interesting because it kind of explored the reason why people continue to take their opioids. And the bottom line essentially was that people are using it to avoid withdrawal, right? So very similar to people who have a true opioid use disorder. And there are ways to safely get people off of opioids and taper them very slowly over time to avoid that withdrawal. And a lot of fear from people on chronic opioids is that, like, oh, I tried getting off of it before and it was awful. Well, it was probably too fast of a taper and too high of a taper. And so I think that that's really an important thing to be aware of. And tapering, I could talk about for the next half hour. So if you guys have any questions about opioid tapering and somebody who's on chronic opioids already and whether they're appropriate for a taper or what should the taper look like, please reach out to me. I'm happy to chat about it. Okay, so essentially, I kind of buried the lead here. Nikki, I can't remember where you're taking over. I'm just going along. Okay, cool. All right.
Okay, I'll take over here.
Thank you.
Yep. All right. All right. You can see that now, right? Okay. So this is sort of the big, one of the big studies that really had us relook at, right, the impact of opioids on pain, right? And so this was a large systematic review and meta-analysis, which ultimately showed that it can provide a benefit for chronic non-cancer pain, but it's very, very small. So again, you have to really think about what are all these risks that that can occur when patients have long-term use of opioids, right? So one of the challenges is tolerance, right? Because it is a full agonist, you get that dose escalation. We also see opioid-induced hyperalgesia, right? So that's when the patient experiences significant pain, and it's worsened by the opioid. So one of the things that's interesting is actually, like, so when we've tapered, patients sometimes don't believe you. So they'll be like, no, they've always related taking the opioid to feeling less pain, and that's true in the beginning, right? But you can talk with them. Well, over time, do you feel like that medicine is helping as much, or do you feel like you need more, or do you feel like, what's your pain on a scale of 10 out of 10? And they're like, it's always 10 out of 10. And it's like, well, this isn't working, right? So, and so talking with them about that. When you have that discussion, you can talk about a taper plan, which Brianna is very excellent at, and we'll talk a little bit about that. But when you do it, you have to do it very slowly. But as you peel off that medication, patients actually improve in terms of their tolerance of pain. But it takes a while for the patient, of course, to buy into that because of what they felt when they first took the opioid that they remember, right? I was in pain, I took this, it made it go away, right? And so that's sort of like that psychological process that you have to break. So say you've got someone who has chronic pain, they're not on an opioid, but you've exhausted all of your other options, right? And you don't want to put them on an opioid, but it's really impacting the function. It's impacting their life, their ability to work, whatever it may be. One of the things that you can consider is buprenorphine for chronic pain. So there's a Butrans patch, which is like specifically for pain, but then we also use the buprenorphine naloxone or the mono product off label to treat pain. And it can significantly impact pain. The dosing is a little bit different. So for addiction, we do it once or twice a day, and it's really focusing on withdrawal and cravings. And when we use it for chronic pain, which there are plenty of times where we use it for patients who have OUD and cancer pain or chronic pain, or just chronic pain in general, it just happens to be a safer product for them, then we want to dose it 3 times a day, right? Or 4 times a day, depending. So you split the dosing. One of the things that's super interesting is if, especially in your elderly patient population, if you're thinking about if you maximize all their non-opioids, right, and they're still having pain, buprenorphine is a much safer product to use in terms of pain control than a full agonist opioid because of the fall risk, the mental cognitive effects of full agonists. Partial agonists, buprenorphine has not been shown to increase fall risk or increase that cognitive processing. So that can be, pretty impactful and important when we think about our patients who are aging, who may have significant osteoarthritis, but not be surgical candidates for a knee replacement, right? But we want them to continue to have function. And so this just, again, is that study that shows how much morphine when they were their pain requirements after they were started on sublingual buprenorphine. So of course, we had this crisis, the opioid crisis. Some of it was prescribed, but some of it was, especially in Chicago, was heroin's just more readily available than prescribed opioids. But you had this sort of the CDC came out with these massive guidelines, right? And so you had a lot of fear and a lot of challenges for clinicians. And so many of them immediately stopped patients, opioids who had 90 milliequivalents or higher, or did too quick of a taper for those patients. And so what was really good was that the CDC in 2022 came out with an updated recommendation that really sort of balanced what had happened last time. So we went from prescribing too much to then being so scared to prescribe at all and cutting people off, but then risking them using illicit opioids, right? Which is sort of what we've seen. So what is the clinical practice guideline? So it's a tool to help improve communication, to make person-centered decisions. It's intended for those who are 18 and older, acute pain, subacute pain, and chronic pain. So sort of separating those out. And it's intended to be flexible for person-centered decision-making. So again, we're really trying to focus on that person's whole person and well-being and outcomes. It's not to replace your clinical judgment, right? If you determine with the patient that an opioid is appropriate, then all you have to do is document that, right? So use your clinical decision-making, if you've exhausted all those other options, that's okay. And you've had that risk-benefit discussion with them. It's not intended to be inflexible, right? We shouldn't, the government or Medicare, Medicaid, any of these insurers shouldn't be using this as a way to rapid taper, abrupt discontinuation of opioids for patients. So don't use this in your clinic as like a rule tool, because that's not necessarily best practices or standard of care, right? It's not a law or regulation. It's not a substitute for FDA approval or labeling. And it's not always as necessarily applicable to sickle cell, cancer related to pain, palliative care, or end of life care. And you're like, well, why are you talking to me about this? Well, because your patients, you don't want your patients who survived cancer to end up with opioid use disorder. Or if they have OUD and cancer, you don't want them to relapse or worsen it. You don't want them to die of the cancer, and you don't want them to die of an opioid use disorder or accidental opioid overdose, right? So it's all about sort of that balance and helping. Always say to the patient, how can I help you live your best life? And what does that mean to you, right? That's not necessarily a pain scale number, it's a functional status number. So that's what you're sort of help the patient redirect them to focus on. And then also focus on treatment of opioid use disorder if you do find it. So in a nutshell, non-opioids can be just as effective and are preferred for subacute and chronic pain. Maximize the non-pharm and non-opioids. Discuss realistic
benefits and drawbacks of opioid therapy, both short-term and long-term, set goals and expectations, right? If you're initiating opioids, use immediate release in the lowest effective dose. For acute pain, prescribe enough for expected duration of that severe pain, right? But not really beyond that. And really continuously evaluate that patient, every 1 to 4 weeks. You don't want to do a dental extraction and then give them 3 months of Norco. Like, that doesn't make any sense, right? Because if that person has a predisposition to an opioid use disorder, you put them at increased risk, right? And one thing that I don't think everyone fully understands is that substance use disorders are both genetic, behavioral, and environmental. So very similar to diabetes and hypertension and hyperlipidemia, the genetic penetrance is about 40 to 60%, depending on the type of substance. So if the patient has that genetic sort of predisposition, and then perhaps has a trauma or experience, and then we environmentally give them 3 months supply, you're really negatively impacting them, right? So it's really sort of important to have that sort of onset. They did this study back in the early 1900s, pretty unethical, wouldn't have it done now, of course, but they had volunteers in the jail system volunteer to be injected with morphine. So as well as the jailers, right? So like the cops that are in there, and they asked people to describe who'd never had morphine before, how they felt when they were injected with it. Some people were like, oh, it helped with some aches and pains. Some people were like, oh, it made me feel sick. It didn't really do much. And then about a third of the people said that it pretty much equated to they felt like they were hugged by God, right? So again, that really initiated or instigated, right, that environmental behavior and that genetic component that can occur with this. So that's sort of just important to understand that if someone has a lot of trauma in their life, and this takes away some of that feeling, that can be again, it's natural for people to not want to be in pain, whether that's emotional or physical. Helping them sort of understand what that impact could be is really important. So risk mitigation, again, that full history is really important. You can also, there's a SOAP tool that you can use to see if they're at risk for opioid misuse. You can avoid co-prescribing opioids and benzos. Please don't do that unless you absolutely have to. There is a co-occurring sort of impact with that just increases the risk of respiratory depression. There was another study that was done for OTPs that looked at accidental overdose, and the most common was during the initiation phase of methadone with short-acting benzos, so like not Klonopin,
Xanax.
Alprazolam. Yeah, Xanax, the devil's drug. So that one, yeah, so it's very right. So like that just increases their respiratory depression pretty significantly. So just be very cautious with that for patients. Co-prescribing other CNS depressants. Of course, it should always be based off of shared decision-making and informed consent, right? They have to know what the impact can be, and then make sure they sign a controlled substance agreement. Co-prescribe naloxone always. This, it's now going to be over the counter. Just flood the whole country with naloxone. It's the same thing as having AEDs or, CPR kits around. You can really save someone's life, right? Just by having it available. It only works if they have opioids on board. If it's anything else, it's not going to do anything to them. So it's really only effective in an opioid overdose. And that can happen anywhere, on the train, anywhere. So just sort of important to have. Review the PMP and document an EPIC. You can do that, right? That reminds you to do that. And then have the addiction talk. It's not required by law, but it is really good patient care, right? So then
it is required by law now, actually.
Oh, shoot.
For every new opioid prescription, you have to cancel and document that you canceled on the addiction potential.
Did that change with the recent DEA?
I think it changed at the beginning of the year.
Okay.
In January. Yeah.
Okay. So document that. I'm seeing the slides. Okay. Um, then you also can take a look at different countries' guidelines, right? And so what is more sort of in line with Canadian guidelines versus US guidelines versus like UK guidelines, that can be, really helpful. Very important that if you are going to do a taper, make sure that it is very, very slow, right? You do not want to induce withdrawal. You do not want to induce uh, any of those like anxiety feelings, right? When you're doing a taper, you want it to be as slow and safe as possible. So to mitigate any of sort of that impact on patients and how they feel. And of course, try to avoid opioid therapy if you can, if they have a history of substance use disorder, because of that increased risk. But sometimes we have to use it, right, in cancer and potentially survivorship. So just having that risk benefit discussion with that patient, caring for them closely. And most patients are really honest. If you give them space to be honest, and then you're not just going to take everything away from them, they will be honest with you, because patients with substance use disorder or anything, it's not that they want to die, right? That's not their goal. Their goal is to, perhaps not feel something, to feel better, but their goal is not to die. And so they don't want to accidentally overdose. So it's important to sort of have these discussions with them. Again, I know we're running out of time. Opioid reduction, again, if patients are on greater than 90 milliequivalents, it's really important to have that risk benefit discussion with them. Evaluate if they have OUD, if they do go directly to buprenorphine. If you can also offer a rotation to buprenorphine versus a gradual taper. Again, reach out to myself or Brianna if you have any questions about how to do an appropriate taper. We can give recommendations, for you and how to work with the patient. Very important to prescribe those adjuncts, right? Medication to help, whether that's clonidine, Tylenol, hydroxyzine, gabapentin, trazodone, really, aggressively address sleep. All of you who've done call know how awful you feel the next day, right? When you don't sleep for 24 hours. So if patients aren't sleeping, that's going to worsen their pain, right? And then nausea, diarrhea impact those too. And then if OUD emerges or they're unable to taper, then you just can do a rapid induction for them. So what about cancer pain? Can you use buprenorphine? And in fact, you can, and it can be pretty effective in terms of a use. And we've done it with Dr. Feldman and Mary Pasquinelli and some of the other HEMONC team members when a patient has had to undergo surgery and they have OUD, or even if they don't, and we would just want to mitigate risks for that patient, you can use it as well. So we have a patient case for you. LR is a 62-year-old female, has been referred to you from HEMONC. This is your first visit. The patient states her oncologist will no longer prescribe her opioids for her pain management now that her cancer is in remission. She's got a past medical history of malignant neoplasm of the oropharynx, status post chemo and radiation, in remission at present. Type 2 diabetes, diet controlled, anemia, bilateral knee pain, history of TIA, history of GI bleed. She's on aspirin, pantoprazole, iron, furosemide, lovastatin, lisinopril, senna, and oxycodone. Her pain is really located in her throat. She's got ongoing sharp pain that radiates to her neck and shoulders. It's localized over her left ear, 8 out of 10 today. She can't take NSAIDs. Gabapentins cause wheeziness and diarrhea, and venlafaxine cause nausea, vomiting. Hemoglobin's 8, blood glucose is 133, otherwise normal. So what are the other things you want to know about this patient to assess her opioid therapy? Is her opioid therapy appropriate for her pain? Does she have an opioid use disorder? And then what adjuncts or alternatives can we consider for her? What do you guys think?
Well, for one thing, all patients, I think, I was going to point out, it's very important to talk to them about sleep and other factors going on in their life balance all that.
I like this patient case because I think there's a lot of directions to go. I'm sorry, somebody else was saying something. I'm not gonna cut them off.
No, I was just seeing, should I pick someone?
I always feel bad
Who
about that.
who would continue her on her current oxycodone regimen?
Remind us what it was. Can you go back a slide?
10 to 20 Q4 hours. And she's pretty much taking it that way.
And it's oxy.
Oxycodone.
Well, unlike her oncologist, I don't think I would stop her opioids, but I think we'd start to have that discussion, right? I mean, she needs pain management. So yes, the goal would be hopefully to stop her, but she needs, if we're not giving her adequate pain management, like you said, she may turn to illicits or other things. So we're going to fail her miserably. So yes, in the short term, but I think the long-term goal would be to get her off of these if we can, although I have to say I struggle a lot with the head and neck patients, right? Their cancer is gone, but they have so much pain related to the cancer treatment, especially when they're getting radiation and they get fibrosis and they get, they've had skin grafting. And so all of that pain is so difficult to manage.
It is hard.
What about, sorry, this is Kristen. What about the lidocaine, like swish and swallows? Do you guys do that as well for like patients with head and neck cancer to kind of help ease them off some of the oxycodone?
Good point. Yeah, finding alternatives for
Love that.
and finding alternatives like that, and then also starting trying to get them into like physical therapy and activity to move, and that can help to improve the pain too.
We did not consider the lidocaine swish and swallow, so that's a great thing. Thank you for that idea.
There was something else I ran into. Pam, do you remember I was presenting at the survivorship didactics? We discussed the managing throat pain and pain from a head and neck radiation treatment. And it was like calcium chloride solution or something.
Right. There was a different mouthwash, swish and swallow, or that was supposed to have a benefit. I'll see if I can find it, but yeah, we need to get pain control here. We want to get her off opiates, right? Those are the goals.
Speech therapy too.
Yeah,
Speech and language pathology to try to deduce if there is some malfunctioning of musculature, right? Like something they can help as well.
The other thing I've come across, is that, and I know that this patient has probably some cancer related pain. So we want to make sure that her pain isn't due to something else, like a recurrence of her cancer, right? And then look at alternative options for her pain control. But the other thing I've heard patients say, especially, with our head and neckers, but also with any cancer patient, is that suddenly all their other pain, like their knee pain, is so much better controlled with their opiates that they, maybe their cancer related pain is gone, but they want to stay on those opiates because they're helping their other pain so much more.
Definitely.
I did find it. It's calcium phosphate rinses. That was recommended by the Stanford survivorship curriculum. So I don't know if that's something to explore.
Thank you.
And I've sent some of these patients to pain clinic to explore things like acupuncture and other alternative pain management.
What about, I don't know about the nerve blocks. I know I've heard some about like nerve blocks to help with some of that pain.
Love it.
What would you guys do?
Yeah, is there anything else you suggest?
Yeah. I mean, this is all great. I appreciate y'all's input because these are some things we did not think of. I think a lot of times people have barriers to like acupuncture or like I think she was declining like behavioral health and things like that. But yeah, my approach would be this first visit, I would not stop the oxycodone. I probably wouldn't do anything with the oxycodone. I'd probably refill it. But start planting the seeds about, okay, we're going to monitor and see how things go. I'm going to ask you every day, every visit about any side effects, any risks happening versus like the benefits. And I think she would be a great candidate for buprenorphine. It doesn't seem like this is a very effective pain regimen for her. But yeah, I agree with you. I would start planting the seeds about a transition or a potential taper. Maybe we can get her to a lower dose. The other thing is oxycodone has been the most explicit or explicitly implied in opioid-induced hyperalgesia. So could we potentially get her down to a lower dose and transition her to like a hydrocodone acetaminophen, and things like that. So lots of options here, but I agree, I would not stop the oxycodone today.
Yeah, and I think that's the biggest thing, right? If you want to support this patient and patient engagement, right? And part of that is building, that trust at the beginning. Now, that doesn't mean that you're going to agree that you're going to fill it for forever, right? But that does mean though that you can, you're going to work with her to find the safest, most effective dose of that medication, or switch to another medication that may do better, because the reality is her pain's still 8 out of 10. So even with all of that, it's not really working that well, and she likely has hyperalgesic syndrome as part of it. And so getting those adjuvants, switching to the different type of opioid, potentially switching to buprenorphine, and then especially as she ages, because like you said, with your head and neck cancer patients, sometimes they end up having pain indefinitely. We have osteonecrosis of the jaw, all sorts of things. So thinking about, you're going to have an aging population, how do you want to safely manage that pain that's unlikely maybe to go away completely, but also manage their cognitive and fall risks and all of these things? And so that can be sort of better managed with buprenorphine as they age.
Yeah.
One last thing I'll say is, sorry, I think she was referred to us because they thought she had an opioid use disorder, and I believe she did not. I think she just had uncontrolled pain on an opioid.
And some people do, like there's right now, I think Natalie's done some, or told me about some studies where people metabolize pain medicine differently, right? So some may not be effective for them, right? Or not as effective because they are hypermetabolized or something like that. So you can't just because someone's on a high amount doesn't mean they have OUD, and it doesn't mean they're selling it. Like, could be, but it also could not be. So that's it's important to sort of differentiate that out.
How often do you pull in like pharmacogenomic testing for patients?
I would love to do that. I don't know how to get that covered. I've never actually done that, but I think that would be a really like incredible tool to be able to use with patients. I would love if our hospital would invest in like a more expansive pain management program here in palliative. That would be really wonderful, because then you could have like that sort of full spectrum. I know most of our pain management does a lot of like, I think they do a lot of like interventions, but I don't know how much testing they do.
Yeah, I know there's a whole new cohort of palliative care specialists in the hospital too. And so talking with Sanjeev, they're usually not presenting till much later this year, but that's palliative as another good specialty to pull into this to address this complex nature of these patients. So it is after 11, I realize, but this has been such a wonderful talk, and we appreciate you guys, Brianna and Nikki, so much. This has been fantastic and really illustrated the need for comprehensive pain management and a team-based approach to management, which we've done with Coleman,
Yeah.
and published about successfully recently about a multidisciplinary team. These patients need all those different facets and different ideas and different heads thinking together. So Thanks so much for this.
Thank you.
I know
It was
people
fun.
will be listening to this again and again. Bam.
Yeah, this is so helpful. And I do love the idea that like you guys have the case conference so we can bring cases there for your input and do this as a team, especially, if people aren't as comfortable sort of switching to Bupe and using like, right, like getting.
Yeah. And switching to
level.
Bupe, but we're happy to help with that. That we've done before. Sometimes we can, sometimes it doesn't work. We have some patients who have like chronic pancreatitis that we've gotten from GI that we've successfully switched to buprenorphine, some we have not. And some we just get to the lowest, most effective opioid dose possible to help them have a functional life. And that's sometimes what you're going to get. And that's that.
But it is possible for some patients too to work with them. I know I had one. I worked with Brianna, 80 micrograms a day patches, fentanyl patches, and fentanyl. She was like 13 years or so, but we successfully tapered her completely off.
That's wild. That was almost too easy. I was like, that was great.
I know it, but so smoothly. She was a champ. So, but yeah, and then you have to deal with the withdrawal, which I know is a whole nother talk.
Yep. Yes.
Yep.
So,
we could do a taper and withdrawal talk if you need it.
I definitely like
That would be great.
This is fantastic, and definitely put it in the hopper for the next lecture series of options. So thank you so much. I'll let everyone go.
Bye, everyone.
Bye, everyone. Thanks for coming.
Bye.
Bye.
Weekend. Bye.